Okay, this is the ICD-10 guidelines, second video. I'm going to start in the actual guidelines. Now, I'm not going to go over every single one of these, but I'm going to pull out some of the key basic stuff. Obviously, not everything you need to know, but it'll get us started. We'll be back in the guidelines multiple times throughout the next 2.5 months. I'll probably, or 3 months, I'll be on you quite a bit too. You better be reading your guidelines. You better know them. Okay, guidelines start out talking about the different conventions. Most of these we've already gone over. Some punctuation stuff we didn't go over. Here's the NEC and NOS. Other and unspecified. Let's talk about those for just a minute. The difference between them is documentation, obviously. Let's say the doctor diagnoses a specific kind of virus. You cannot find that specific virus in the index. You see all kinds of other viruses, but not that specific one. You would choose other because you as the coder know that the specific virus is documented in your documentation, in the note. So it's not an unspecified, it's an other. It'll fall in an other category, so you would code it. So that would let the insurance company know that you in fact do have the specificity. The ICD-10 just didn't have it for you. Whereas same scenario, you have a specific virus, you can't find it, so you just code the unspecified. That tells the insurance company that you do not have any specific information regarding that virus, and it's completely unspecified. Information includes, excludes. We've kind of been over that. Your etiology and manifestation. This is your code first and code additional, just good information. We've gone through that some. Your and, how you would use and or. With, this is a new guideline for 17 or starting October 1st of 16. With now means that there are some diagnoses that if they're listed in the index under with, then we can assume the relationship. And we'll see specifics of that as we actually get into the codes and the exercises. So probably on the conference calls, we'll kind of go over that some. C and C also, kind of self-explanatory. Code also, we've already talked about that. So then B part, the general coding guidelines, we get into a little bit more specific on what we do in certain situations. That's essentially what these guidelines are. They are the rule book, the instructions, the directions, the guidelines for how to use all the codes in this book. You can't just assume or think if you got to one code that you're good to go. You have to always see if there's some further guidance or further clarification in these guidelines on how to use the code that you're wanting to code. Okay, a little bit on locating. What your dash means, anytime you see a dash in the index, then that means you need extra characters to it. Now, we all know the big rule, we don't code from the index anyway, so you would be verifying that code. So the dash, you're verifying it anyway. When you get to that actual code, it would allude to either give you a stop sign or something that you needed extra characters. Level of detailing, we've talked about that. You have your category codes that are one alpha letter or one letter, and then 2 numbers, and then a decimal, and then you can have up to 4, 5, 6, and 7 characters on the right side of the decimal, and that's kind of what it's talking about. Signs and symptoms. If you have, all notes are going to have signs and symptoms. Think of a SOAP note. S stands for subjective, O stands for objective, A stands for assessment, P stands for plan. Very, very basic note, SOAP note. Your subjective is going to be the patients coming in complaining of a sore throat and a cough. Your objective area is where the doctor actually examines the patient. The assessment is what the doctor diagnoses them with, and then the plan is what are we going to do for it. So using signs and symptoms. You cannot code signs and symptoms that are a part of the actual diagnosed or definitive diagnosis. So let's do an example. Patient has cough and sore throat. Doctor examines them, provides, renders a diagnosis. His diagnosis is upper respiratory infection, and his plan is to give him some cough syrup. It's viral, so he's not going to give him antibiotics. So in this instance, your cough and your sore throat will not be coded because they're a part of the sore throat, or they're a part of the upper respiratory diagnosis. So this blurb is telling you if you have definitive diagnosis, then you don't code signs and symptoms. If you don't have a definitive diagnosis, then your signs and symptoms are all you do have to code. Conditions that are integral, that explains a little bit more. Not integral. Multiple coding for single conditions. This goes into our code first, use additional manifestation codes, use additional, all of that is here. Some of these guidelines overlap a little, which helps you gain ground faster. So multiple coding for a single condition. Patient has diabetes and their neuropathy and their retinopathy are linked to it. So you're gonna link those. You're gonna have multiple coding in order to code all those. That's probably not the best example because that's more of a manifestation. Patient has pneumonia, specifically from staph. So you're going to code the pneumonia first. That's the single condition. And then you're going to code also that Staph aureus because that was the bacteria or the organism responsible for it. So by your pneumonia code, it's going to tell you code also the organism if you know what it is. That's what this is talking about. Acute and chronic conditions. If you have an acute condition and a chronic condition, always sequence your acute conditions first. Always. Acute for everything is first. Sometimes it takes 2 codes or combination codes for a single code. So that's kind of what that's talking about. Your sequela. If you knew ICD-9, this is your late effects. Kind of a long blurb about sequela. Essentially what a sequela is it's the residual. Once a illness or disease has stabled out, quit being acute, then whatever residual or whatever deficits you're left with is a sequela. Here's an example. I have a stroke today. I go to the hospital, I'm in the hospital for 4 days, then I go to rehab for 2 weeks. Doctor wants to see me at 6 months. So I go at 6 months and I'm doing great from my stroke, but my left side's still just a little weaker than my right. I've done all the physical therapy, but it's still just a little weaker. So my sequela, my residual, my deficit from that stroke is left-sided weakness. The stroke is completely resolved, but I have lasting effects from it, and that's what a sequela is. How would you code a sequela? Sometimes for fractures, you code a sequela with the 7th digit being an S for sequela. Your stroke sequelas will actually have their own codes for it, the effect of a past stroke. Impending and threatened conditions, you can code those sometimes. Most of the time we have to code only confirmed diagnosis. We cannot code rule out or I'm suspecting that, or it might be this. We have to code only definitive confirmed diagnoses. But we do have a couple of diagnoses in the ICD-10 that fall under impending or threatened. Impending, the most common, is impending myocardial infarction, which is a heart attack, and there's a code for that. And a threatened, the most common threatened is an abortion. Miscarriage, but they don't use miscarriage anymore. So that situation, you can actually code threatened. Laterality, we've talked about this. If you have the ability to code left, right, or bilateral, you need to code it, no matter what. Different documentation for BMI, non-pressure ulcers, pressure ulcers, those types of codes. Your pressure ulcers give you, or your ulcers give you the ability to code a stage. It's a second code that you would use with them, potentially. And it's just telling you you need to code to the stage if you can. If you can't, if there isn't a stage listed, then you code unspecified stage, or pick the single combination code that has the unspecified. Complications of care. This gives you your sequencing of how to sequence a complication of care. Borderline diagnoses. This lets you know this this can be tricky. Remember, we have to code confirmed diagnoses in the outpatient setting. Inpatient setting is a little different. Outpatient setting, we only code confirmed definitive diagnoses. So this kind of gives you a look at the inpatient versus the outpatient. Use of signs, symptoms, and unspecifieds. This is good information. We've already covered a little bit of it, but it's just a different way. It's written differently. Then in the C, so we've been through A, we've been through B, now we're in C. This section of the guidelines, most of the rest of the guidelines, will actually break down each chapter, each tabular chapter. Remember, I showed you how to know your chapters of the ICD-10. So this is where you would probably come for those specific chapter-related respiratory, cardiovascular, fracture. This is the section where you would actually come for those specific guidelines. So chapter 1 is our parasitic and infectious disease. Lots of guidelines concerning HIV and how you code it when they're asymptomatic, when they're being seen for something not related to their HIV or to their AIDS, how you code it. Really, really good information here. As we go through, probably this coming Wednesday will probably be our basic ICD-10 for our conference call. The next Wednesday is probably going to be chapter specific, so we can go through each of these chapters and answer questions. So make sure by that Wednesday that you've gotten through as many of the chapter specific guidelines as you can. Okay, so still stuff with HIV and AIDS here. Then we go into sepsis or septicemia. Good information here on extra codes that you have to pick up if it's severe sepsis or with septic shock. How to sequence your severe sepsis. If it's a localized infection. If the sepsis is due to a post-procedural infection, how do you code it? Sepsis associated with a non-infectious process. Sepsis with pregnancy, tells you to go someplace else in newborn. MRSA, types of sepsis, or no, MRSA, now we're in a different section. MRSA infection, how to code that. SSA please, on page 12, know the difference between MRSA and MSSA. R is resistant, S is susceptible. They're vastly different diagnoses. We even have some Zika virus. This is brand new stuff, so how to code that. Then we're into our chapter 2 of neoplasms. Here you will find out how to code what the sequence. Now remember, your guidelines really help you on sequence and picking up extra codes, how to actually code that scenario. Here's your neoplasms. Give some good information about your neoplasms. We're going to talk about the Neoplasm Table in just a second. Treatment of malignancies, if there's a secondary site, how to sequence. And if you see, this is C, and we have 1, 2, 3, 4 different ways, different scenarios to sequence under C, whether it's anemia with the associated to the malignancy, anemia with the chemo, dehydration, treatment resulting from a surgical procedure, very, very specific. If your primary malignancy was previously excised, then we get into specific admissions and encounters for involving chemotherapy. If I were you, I would get a piece of paper right now, and we're going to kind of make a list of, remember in the first video I said, now there are some terms that I can give you that will help you find stuff, especially for your health-related, your Z codes, in the back of the ICD-10. And I told you that you would see a list of different, or be able to make a list of different kind of trigger terms that would help you find codes. We just passed some. Admissions and encounter. Admission and encounter. Those are two really good codes. Really good words that will help you find those kind of weird codes that are usually Z codes. And if you look down in here, they're primarily talking about Z codes. So to find this area that they're talking about, you probably will stand a good chance of either going to admission for or encounter for. So put that on a piece of paper and make your list. That will help you in the end find these codes. And there'll be more. Keep your paper out. Signs and symptoms. We're still in neoplasm, still in chapter 2. Admissions for pain control. How do you sequence that? Sequencing neoplasms, if the primary is being treated or if the secondary is being treated and not the primary. Just really good information in here. So this is all for your chapter 1. Your chapter 2, sorry. Chapter 1 was the HIV and sepsis. Chapter 3, bloodborne stuff, we have no guidelines on that. It tells you this is reserved for the future. So yeah, you don't have to worry about that. Chapter 4 is your endocrine, your metabolic stuff. This is where your diabetes is. So this goes right into diabetes. It tells you, and please, please, please listen to this. We have 2 kinds, actually 3 kinds of diabetes, but 2 types. There's a type 1 that's insulin dependent and a type 2. Type 2 is the default. If your physician is talking about the patient having diabetes and never gives a type in the note, you assume it's type 2. That is a guideline. You must do that. Even if that diabetic patient that he has not documented a type on is on insulin, it is still a type 2. The only time you code for a type 1 diabetic is when they tell you type 1. They cannot tell you this is an insulin dependent patient and you assume it's a type 1. You cannot do that. Please, please, please listen to me. You cannot do that. Default is a type 2 unless they tell you it's a type 1. The other kind of diabetic is the pancreas got removed, so you're automatically a diabetic. Something happened, which then the manifestation is diabetes. But that is, those are secondary diabetes and not very common. Okay, so now that I've given you that blurb, they're going to tell you the same thing that I just told you. Here are your diabetes and insulin on the oral. Complications of insulin pumps that have been put in, secondary diabetes. If your patient is a type 2 or just a diabetic, they either tell you they're type 2 or they don't give you a type, and they're receiving insulin, then you must code the long-term use of insulin for them. I'm going to go to some examples when we finish here. Mental health. Thank goodness we finally have a little bit of guidance here. This kind of gives you some guidance. This is chapter 5. Different mental health and psychoactive, different substance issues and that kind of thing. Chapter 6. This is your nervous system. Pain codes are in here, which aren't great codes, at least for insurance to pay. How you sequence pain. Postoperative pain, there's specific codes for that. Chronic pain, neoplasm related pain. Into chapter 7, this is the eye and adnexa. So it gives you some different glaucoma guidelines, how to code for glaucoma, the types or stages. Chapter 8, we don't have much guidelines for the ear. It's pretty self-explanatory. Ears are easy. 9 is our circulatory. This is where we get into hypertension and heart attacks and that kind of stuff. So here, hypertension, this is a brand new because it's bolded in black. This is brand new this year, telling us that we can, now that we have those new with guidelines, we can actually assume some relationships between hypertension and heart disease. Hypertension, we could always assume it with kidney disease, but now they've made the change that we can include it with our heart disease. So if you have hypertension and you have heart disease, you would use out of this I-15, or no, sorry. They're telling you here, sorry, I'm looking at two different sets. You use out of the I-11 for your hypertension, but then you go into the I-50 or I-51 series to pick up your heart linkage. So most of these will require 2 codes now. Your hypertensive kidney, you would use your hypertension code out of the I-12. Your regular hypertension code is I-10, and I don't even think it tells you it's that. So regular is I-10. Hypertension with heart is I-11. Hypertension with kidney is I-12. Hypertension with heart and kidney is I-13. So when you're using an I-11, I-12, or I-13 series of codes, then you have to go pick up extra codes, and that's what these are telling you. Your I code would be, or your I-11, 12, or 13 code would be representative of the hypertension part of the diagnosis, and then your I-50 or I-51 would be for the heart. You're in here, you're in 18.1 to 9 series would be for the chronic kidney, and then you would be picking up a couple of codes here. You would have to pick up both of those, the one from the I-50s and one from the N-18s. Okay, that is actually easier in practice, I promise. Hypertensive cerebrovascular disease, hypertensive retinopathy, secondary hypertension, controlled hypertension, uncontrolled, hypertensive crisis. This is new. This is an I-16 category. This is all having to do with hypertension and its combination on something or the behavior of the hypertension. Here is your sequela of the cerebrovascular disease. So you can link it to, and it tells you these are like the late effects. You can link it to the site of weakness, to aphasia, whatever it is. Now we get into our acute MIs. Oh, damn it. Okay, so it does start right there. So on 20 starts with your acute MIs and how to code them. You have STEMIs and non-STEMIs. This is really good information. That's the kind of detail that you're going to need in order to code your specific scenario. If you have subsequent MIs and the time frame, what is considered an active MI, how long you code it active, it's up to 4 encounters after 4 weeks of time from the original MI, then you code as an old or a healed MI. Those are the kind of guidelines that are just critical. If I were you, that kind of specifics, if it gives you a time, how long you can code something, this gives you 4 weeks. You can only code an acute MI for 4 weeks. So I would make note of that. Then we're into chapter 10. This is respiratory, how you code your COPD with asthma, how you code your COPD with acute, or how you code your acute respiratory failures. Sometimes you have acute respiratory failure and other stuff, so that gives you your sequencing. Sometimes you have acute respiratory failure on chronic respiratory failure. That will be explained in here. Different ventilator-associated pneumonias, influenza down here. Then we get into chapter 11. There's nothing for digestive further than what the book gives you already. Chapter 12, this is your skin. So this goes into great detail about what to do about those stages, what's unstaged, what you do, pressure ulcer, the documentation that you need, patients admitted, that kind of thing. Anything in the bold has been added this year, so it's just adding further clarification usually. 13, musculoskeletal. This is the section that really blew up with the ICD-10. We just have a lot, like 30,000 more codes in musculoskeletal, the fractures and those types of injuries than we ever did before. Kind of helps you bone versus joint, how you code pathologic type of fractures, your osteoporosis, all of that's in here. 14 is your genitourinary. These are your N codes. Here is your chronic kidney disease. Then we get into pregnancy. If your patient is pregnant, then anything on the chart is going to be linked to that pregnancy. It's going to be an O code. A whole bunch in the pregnancy. We'll probably on a conference call kind of have to walk through, because these codes can really stack up depending on what's wrong with your patient. Talking about, you have to track the trimester. If you have codes for the different trimesters, then you have to use them. For every pregnancy code, you have to have a weeks of pregnancy code. I'll show you that in a minute. You have to track if there's multiple fetuses or not. Any pre-existing issues. If the pregnant mom already had diabetes or already had hypertension, those are pre-existing, so they're always a part of that pregnancy. At the end of pregnancy, you always have an outcome of delivery. This Z37 always goes on the mom's chart. Please make a note of this. You cannot put a Z37 on a newborn chart. You'll get denied immediately. They have their own code. You have to use the Z37 series for an outcome of delivery. Here's your normal deliveries. If it's uncomplicated, different issues during it. You have your different issues with abortion or miscarriage. Do you have products of conception still left where you have to do a D&C, something like that? Chapter 16 still has to do with now it has more to do with your newborn. You don't ever, it tells you, you don't ever use anything from chapter 16 on a maternal chart. That's the very first thing it's telling you. Your Z38 series is that outcome and delivery that you put on the newborn chart. So Z37 for moms, Z38 for babies. You cannot put a Z38 on a mom's. You cannot put a Z37 on a baby's. They have their own. These all have to do with the status of that neonate when it's born. 17 goes into some congenital malformations, congenital issues. 18 goes into our signs and symptoms. We've already talked quite a bit about those. There's a lot of good extra information in here that kind of pertains to a lot of other sections like the SIRS. Sometimes the SIRS plays a part in septicemia. It could. Chapter 19 are your injury codes. It lets you know what superficial injuries are. It lets you know how to sequence if you have nerve and blood vessel issues. It lets you know that most of these all go to the 7th character, and that your A is an initial, your D is a subsequent for your 7th character. Open fractures, burns. With your burns, you always have to have a second code that gives the percent of burn. That's one that I always forget about when I code my ER charts. Always forget that. I have sticky notes to remind me to go to sticky notes, and I still forget it. Poisonings. This is generally speaking drugs or chemical poisoning. And I'm fixing to go over the actual tables with these in just a minute. I just want to get through the guidelines right now. Gives explanations as to the different poisonings, underdosings, toxic effects, complications of care. This is a good kind of overall issue, place to go for a complication issue. Say that the patient's having a complication because of pain of a medical device that's been implanted. This will give you guidelines on where to find that code. Transplant complications if they've had an organ transplant. Complications with different body parts because of external causes. Those are the T codes. This is kind of a good, little bit generic. Then we go into chapter 20. This is the external cause. So we have, remember, we have our own index for external cause. So this is some guidelines on how to use them. That you need a place of, so you have A, which is just your general. Then we have B, so you have one code for your A section. You have one code for your B section, the place of occurrence, and then one code for your C section, activity, although we don't necessarily do that a lot anymore, but it's still here. And then D is just kind of a pulling it all together. So you could potentially have 3 external cause codes for one condition or one injury. You would have how it actually happened. This would be, I fell down a flight of stairs. I tripped on a wet floor. I got hit by a car. I was driving and was in a motor vehicle accident, that kind of thing. Your place is where it happened. I was at my house. I was at the park. I was on the freeway, you know, whatever that is. And then activity. Your activity generally is speaking to, were you on the job when you were doing it? Are you civilian or military? Were you doing it for leisure? That's what your activity means. External cause codes give me huge headaches, so don't get freaked out about them. They're a pain in the buttocks. Terrorism, just a little bit of extra information in here because of the sad world we live in. Chapter 21, factors influencing health. These are those Z codes that I said that you might want to make a list about. That might help you find codes better in the index. Status is another word. So we have admission for, encounter for, status, contact or exposure to. Those are good words. But this kind of breaks it down, what you can expect. There's observation codes for different stuff. This is kind of a long section. Once you're coding the section of Z codes for a practice, you will probably want to hang out a little bit more in here. Miscellaneous Z codes. As you see, there's this many miscellaneous as there are labeled. That's how crazy it is. Okay, then we are moving out of that section. We're moving into section 2, and these are the guidelines on how to pick your first listed diagnosis or your principal diagnosis. Depending on if it's a principal diagnosis, if you're inpatient, it's first listed. If you're outpatient. But this kind of tells you, this recaps some of what we've already talked about. Symptoms, if you have more than one interrelated condition, if 2 or more diagnoses can be the principal, how do you pick them? Sometimes it depends on what got the most attention or got the most workup, but sometimes you can't decide that. How to code either or type of stuff, symptoms, uncertain diagnoses. This is where you'll get your information about what you can code, whether you can code it, going into this section 3. Specifically, see your uncertain diagnoses, probable, suspected, likely, questionable, possible, still to be ruled out. Those are not definitive diagnoses for us, so you cannot code any of them. Previous conditions. This is just really basic. This is section 3 going into section 4. Talk about how you select. This is specific to our outpatients, so this is a lot more relevant to what we do as CPCs, whereas some of this other stuff had a little bit more to do or overlapped into the inpatient. This section 4 is very much only us as outpatient physician-based coders. How you select your first listed, outpatient surgery, observation stays, level of detail in coding. A lot of this is just a repeat of what we've already seen. Again, uncertain diagnoses, talking about patients who are receiving diagnostic services only. Then their first listed is probably going to be a Z code. That's when you would use that admission for or encounter for. Patients receiving therapeutic services only, that again, that's admission for or encounter for. Okay. And then we have present on admission reporting guidelines. This is very much inpatient geared. You will not be tested on the board for any present on admission information. I wouldn't worry about it. Feel free to read it anytime you want, but you will not be tested on it on the board. This is for inpatient only. Okay, so let's look at our Neoplasm table. We know our guidelines, or we've seen our guidelines now. So how do we read this table? You have it labeled. It's on page 467. And up at the top, you have 6 different categories. You have a malignant primary and malignant secondary. That means they're cancerous. A cancer in situ, a benign and uncertain behavior, and an unspecified behavior. So typically, your unspecified behavior means there's a tumor there and they don't know if it's benign or malignant, which we all know is few and far between. They will always be able to determine what is benign or malignant most of the time. So this green column is hardly ever used. Primarily what you're going to use in here is your malignant, your primary, your secondary, and your benign. And so then how you read this is you just go down, starts with the A's, and you find your body part. You find your organ. You find your problem. If it's the aorta, go to that. If it's the larynx, find the larynx. Really get used to what is at the margin and what's indented, because that will help you. And so as an overview, that's how we use this. Cancer in situ very much has to be diagnosed as cancer in situ. This a lot of times has to do with the breast, but not always. Obviously, there's a lot of other, but very common for us to see cancer in situ for the breast. Uncertain behavior, the only time that we would use that is if the pathologist actually rendered an opinion that he cannot decide. He is uncertain as to if it's a benign tumor or a malignant tumor. So the pathologist actually renders that uncertain behavior. You do not code uncertain behavior if the doctor says, well, I'm not sure if this is benign or malignant, so I'm going to send it to the lab. That you do not code. In that scenario, if you're coding that moment in time, you code it as benign. You would default as normal, and normal is benign. Normal is without cancer. Okay, let's go to poisonings. Our poisonings table kind of looks the same on page 495. And across the top, we have poisoning accidental or unintentional. Then we have intentional, so we're trying to hurt ourselves. Assault, poisoning undetermined, poisoning adverse effect, and then underdosing. This underdosing is new. So how do we code these scenarios? Generally speaking, if someone comes in and it's determined that they've been poisoned by comet, unless the documentation tells you that that patient was trying to kill themselves, you will always default to accidental. Don't ever, even if they've got a bottle of Tylenol in their belly, unless the doctor has said that it was a suicide attempt, always take it as an accidental, because you could have an 85-year-old little lady that lives by herself, and you know her arthritis is terrible, and all she wants to take for it is Tylenol, but she's very forgetful, so she could have taken 2 Tylenol at 8 a.m., forgot about it, took another 2 at 10 a.m., took another 2 at 1 p.m., took another 2 at 5, and you know, she's just forgetful. She forgot. She's not trying to kill herself, but she may very well be poisoned by Tylenol and end up in the emergency room. So you would still do this as an accidental. Obviously intentional, that if your documentation tells you that the patient was actually intending to hurt themselves, then that's when you would use this. Poisoning assault. This is somewhat common, like in the going out to the clubs, if somebody slips you a Mickey, that's what we used to call it, gives you a roofie, whatever, that would be an assault with a drug assault. Poisoning undetermined, that means it has not yet been determined if one of these scenarios apply. Undetermined would require a bit of documentation. I need to see in there that the doctor's like, well, I'm not sure if she tried to kill herself or if her husband really is that mad at her or what's going on. Then we're undetermined because there are other scenarios out there. If the doctor just doesn't tell you, then you assume the accidental. Adverse effect. Patient is taking the medication as they're supposed to, and they have gotten a rash, or they got sick, or they're comatose, whatever it is, they've had an adverse reaction to taking their medicine. Underdosing. Patient is supposed to be taking that insulin 10 units every morning and every night, but she decided she didn't want to. So she's now in the hospital with diabetic ketoacidosis because she didn't take her insulin. So she is underdosing on her insulin. So that's how we would use all these poisonings. They are alphabetized. I think most of them are generic. So for Tylenol, you need to know it's acetaminophen. Acetomorphine. Where's acetaminophen? Acetaminophen. There it is. So kind of keep that in mind. You might have to Google if in the real world, if you're trying to find a drug in here, you have to Google sometimes to get the actual name of the drug. For the purpose of the board, they will give you, obviously you don't have your phone, so they will give you the drug as it's seen in here for you to have to find. Okay, so that is the guidelines. That's how to use these tables. Hopefully that will get you a little bit further. Your external cause index, I guess now that we're in there, let's look at it real fast. Starts with the A's, obviously. Your motor vehicles are going to be under accidents. Some of the other trigger words, struck, like if something hits someone, struck is a good place to go. Fall is a good place to go. Contact with is a good place to go in these external cause. Now this is just external cause. There's one list for finding external cause codes. There's another list for finding those Z codes. Oh, and I was gonna show you in your textbook. Let me get to the page. Just a minute, you guys are going to see me flipping for a minute for me to find it. Your chapter 4 is super duper long, but it specifically goes through every one of these guidelines that we just went through. That tells you how important these suckers are. Just a minute. Oh, that's letting you know about your burn percentage. That is, I don't think that's, just a minute. I really did find something. Okay, here is a good rundown cheat for your motor vehicle accidents. I actually have this kind of written and it helps me in my day-to-day. That was on page 179. And then your Z code right here. These are your great words to help you find these Z codes. This is really, really, really helpful. It's on page 184. And I don't know if you see our admission is on there, our encounter 4 is on there, status is on there. This is the list. So I don't know if you maybe want to write these down somewhere in your ICD-10, and when you know you're dealing with Z codes, you can go kind of look at this list and help you get there faster. Maybe, I don't know, but that's a really good cheat that's in your book. Okay, so that is it for guidelines. So you're going to have 2 weeks on these, the ICD-10, and then we'll have 2 conference calls too. So I think you'll do fine.